you and with my GP colleagues. So I think the topic which we agreed on is how to assess an eye in 10 minutes. The question is treat or refer from the GP point of view. This is a bit of tricky question. So all I'm trying to do within the next slides is just to make kind of agree on pathway, both of us, and then try to apply in practice, or at least slightly see whether you need to change any of your referral habits, or just stick to what you are doing according to this. So as an overview to the slides, the first few slides will be about basic anatomy to the eye, and then what's needed to assess the eye at the GP surgery from my point of view. And then key question you need to ask the patient while taking the history. And then we'll just show some clinical examples for discussion. And the end will be about questions and comments from your point of view. So starting from the anatomy, very easy and simple anatomy to the eye. So let's concentrate on this part. All the tears are produced from the lacrimal gland, which is usually based on the superior temporal part above the eye. And they are produced from here, from the glands, from the lacrimal glands ducts. They are going into the eye, and then they are drained into the lacrimal duct. And on the margins of the eyelids, we have the eyelashes, and in between the eyelashes, there are the, we call it accessory lacrimal glands. So there are some production of different layers of the tears coming from this area. So the actual watery component of the tears coming from here. However, the lipid layer, in addition to other component, they are coming from glands which are produced or located in between the eyelashes. We have the sclera, which is the whitish part of the eye, covered with the conge. The conge is usually the bit which can get injected whenever there is any inflammation. And then there is the clear window at the front of the eye, which is the cornea. Behind the cornea, we have the iris, which is the colorful part of the eye, and obviously the pupil. And this is the kind of cut, axial cut through the eye, and that's the cornea here, as we agreed, the iris, and there is the lens behind the pupil. There is the vitreous here, which is a large cavity which contains the jelly at the back of the eye. And then there is the retina at the back of the eye. And in the center of the retina, there is the macula, and that's the most important part of the retina because 90% of the central vision is coming from the macula. And lastly, we have the optic nerve, which is transferring the image from the eye to the brain. So this is another shape just to show you how is the eye is surrounded with a lot of tissue, not only the eye itself. We have the muscles, we have the nerves, we have the sinuses here. So that's why not every single pain coming from the eye is related to the eye. It could be related to these tissues around the eye. And the other thing, again, that's another slide to show you the anatomy. The optic nerve transfers the image. It goes through the optic chiasm, and the pituitary gland is very close. So any lesion of the pituitary gland, it can affect the chiasm. And then the whole thing will go to the primary visual cortex. And it's very important to know that any visual field defect respecting the midline, like for example, in this eye, we have left hemianopia respecting the midline. So whenever we see left hemianopia, the lesion is on the right side of the brain, in the right, possibly occipital lobe. So it's always the opposite side. Again, I think these things you already know about. I'm just trying to kindly remind you about these. From my point of view, what you need to examine an eye at your GP surgery is very simple things. First thing, you need visual acuity chart, and that's something you can either buy or print from the internet and then see what is the distance and stick it on the wall in your surgery. However, even if that's not possible, you can have this handy application, the phone application, which can tell you all about the vision for near, for distance, the color vision, everything you can do in case if you don't prefer to have this. The other thing, you need to have 3 eye drops. In my opinion, no more than this. You need to have numbing drops. It could be oxy, it could be binoxynate, it could be tetracaine, many options. You need fluorescein for sure, and you need dilating eye drops, tropicamide. Again, nothing else. You don't need any more drops. The reason why you need the numbing drops is just because some people, especially people with the corneal abrasion, they won't allow you to to examine their eyes without numbing the eye. So that can be very useful. The fluorescein to stain any abrasion or see whether there is any foreign body hidden under the upper lid. And obviously the dilating drops, if you have any experience in checking the fundus, that's a must. The other thing which I highly recommend as a basic thing is just to have direct ophthalmoscope. Again, it's pretty cheap if you get it from even eBay or any other online source. And the benefit is not only to see the back of the eye. In fact, if you play with this disc here, which can change the magnification, change the refractive status, you can see the front of the eye very magnified. So in other words, you can see the cornea clearly, you can see what's happening in the AC, and then you can move again to 0 to be able to see the back of the eye. Mainly, I'm interested in the macula and the optic disc. I know I'm not asking for anything more than this. And the other benefit, you can have the almost near fluorescein light, check for abrasion, and you can have the normal light, and you can have the light which asks the patient to fix on if they have macular issue with the grid. So that's why this is really useful in checking the fundus and the front of the eye, and it's handheld, very tiny machine. On top of that, you have to have only minimal ophthalmology experience. And the main thing, you have to have basic knowledge, very basic knowledge about ophthalmology. You need to know how to check relative afferent pupillary defect and how to do confrontation visual field. In my humble opinion, if you know how to do these, and if you have this, that's all you need. Within the next 6 slides, I will talk about the key question while taking history from any patient visiting your GP surgery. And as you may all know, and as we all know, the most common issues for any patient visiting the GP is red eye, painful eye, including light sensitivity or photophobia, gritty or itchy eye, change in the vision, not loss of the vision, which can include floaters, flashes, or glare, or loss of vision. And loss of vision could be permanent or temporary. So we'll just try to make it very simple and talk about every single one of these and see what are the key questions you need to ask to conclude at least the possible diagnosis. So talking about the red and painful eye. Again, I think there are always red flags here. And if you see any of these red flags, you need to refer the question urgently to the eye casualty or eye clinic, depending on the situation. The red flags, loss of vision. When I say loss of vision, by definition, loss of vision should be kind of at least 2 lines less than baseline. So let's say if you see a patient who can see 6.6 or near 6.6, but it's a blurry, I wouldn't call this loss of vision. Loss of vision should be significant. The loss of vision can be caused by acute glaucoma, uveitis, infection, so all these kind of things. Again, in the history, you need to ask if the patient is having loss of vision with severe pain, headache, that should give you indication of acute glaucoma, especially if the eye is very inflamed. Uveitis, the main thing with the uveitis is the light sensitivity more than anything else. So patient will say they can't tolerate the light, the eye is quite kind of blurry, and they possibly have previous history of uveitis. That's another red flag. Infection, always ask about trauma or contact lens wear. Any patient with red eye if they are contact lens wearer, they need to be sent directly to eye casualty because of risk of keratitis or corneal ulcer. Same with orbital cellulitis. If you see any signs of orbital cellulitis, especially in young, sorry.
Hello.
Yeah, when?
Hi.
Well, we've got the Bible class on. Can I speak to you after that?
I'm sorry, could you put yourself on mute, please?
Sorry.
Okay. Sorry, shall we carry on, Mel? That's fine.
Yes, please.
Yeah. The other thing is severe pain with headache. As we said, this combination with red eye, it should always raise the suspicion of acute angle closure glaucoma. Any foreign body with the red eye, they need to be referred directly post-surgery because of the risk of infection. And usually, when I say post-surgery, it's usually up to 2 weeks after the surgery, because after 2 weeks, it's very unlikely that the infection will be there. But still, you need to refer depending on the situation. Previous history, especially people who are known to have glaucoma and use the drops, or recurrent uveitis. Those are the red flags for any red eye, plus or minus pain. And these cases, I think they need to be referred regardless. The other category is whenever you see red eye, slightly, I wouldn't say painful, possibly itchy or uncomfortable. So these are the things which you can possibly treat yourself or at least assess without referring directly. If the vision is not affected and there is no significant pain, and the most common reason here is dry eye with blepharitis, allergic or bacterial conjunctivitis, or even viral conjunctivitis, subconj hemorrhage. So these are usually the most common reason for red eye without pain and without loss of vision. As you can tell from this slide, every single disease has its own marked symptom. So let's say the conjunctivitis, the most common symptom from any conjunctivitis, viral, bacterial, chlamydia, I'm talking about microbial conjunctivitis, is the discharges. So you get a lot of sticky discharges, and these discharges could be kind of pus, it could be mucus, it could be watery. In the viral conjunctivitis is usually watery. In the allergic conjunctivitis, it's usually mucus. In the bacterial conjunctivitis is usually pus. So that's something you need to look at. However, if you see red eye without any discharges, possibly think about something else, not conjunctivitis. It could be iritis, it could be acute glaucoma, or infection of the cornea. The photophobia or light sensitivity is marked for iritis. So people with iritis, they will not stand the light. And I will add possibly corneal abrasion on top of that. However, that's not one of the very common reasons, but you can always check whether there was any previous history of abrasion. Pain is very significant in acute glaucoma and inflammation or infection to the cornea. That can be very marked. With iritis, it's unusual to have pain. It's mostly the light sensitivity. However, if this is very severe iritis, they may have pain as well. Visual acuity is usually normal in conjunctivitis and reduced in the other categories. The pupil, it's very difficult to distinguish. However, in the acute glaucoma, you expect large and fixed pupil, which is not responding to any light. So you can't even check whether it's reacting or not. And that usually can happen in acute glaucoma. On top of that, you will have the headache, the pain, the blurry vision, the inflamed eye. Talking about the loss of vision now, red flags, we need to refer directly if this is post-surgery, without question. Any elderly patient with intermittent or permanent loss of vision, because in these cases, in this category, an elderly patient, even if they are having intermittent, you need to think about TIA, GCA, other vascular reason which can cause this. However, if the age is about like 50 or less, usually ideally up to 45, you can always consider migraine. But I wouldn't consider migraine, especially if this is the first time in any elderly patient. Those people, we need to think about the vascular diseases, which could be very serious if not treated or assessed properly. Loss of vision with severe pain or redness, again, as we discussed, acute glaucoma uveitis infection. The benign category, any intermittent blurry vision, even slight loss of vision with symptoms and age fits with migraine. The age, as we all know, the age of migraine is, we are talking about youngish people up to certain age. It can still last after that. However, they need to have previous history of migraine. And migraine usually, it can be in both eyes. However, there are sometimes it can affect one eye, but that's very rare. And it's always comes after, I mean, there are symptoms and then it will be followed by headache, and it can affect the peripheral vision rather than central vision. So it has its own description, which I'm not going to go into details about it. When you examine any loss of vision, please remember visual acuity is quite important because some people, they say, I lost my vision, but you check their vision is 6.6. This is not loss of vision. And if you would like to combine your test, you can add the pupil reaction and then confrontation visual field. If you know how to do this, and if you do all of these and you see no concern, this is not loss of vision and nothing to really be over concerned about. So any loss of vision, any vision assessment, we need to combine all these together if possible. That would be really appreciated in the referral to mention, if you have time and you have basic experience in doing this. The painless change or loss of vision, because it's very important to combine the loss of vision with the pain. So whenever we see painless change or loss of vision, if the patient is mentioning about misty vision or glare, gradual onset over the last few months, mainly affecting the reading, sometimes the driving, the glare. So think about cataract. That's the most important, or let's say most common reason. If the patient is mentioning about distortion of the central vision or central scotoma, they can't see centrally. So they are saying the peripheral vision is fine, but the distortion or the loss is only affecting the central vision. This is definitely macular pathology. Very rarely could be optic nerve, but mostly macular pathology. Flashes and floaters, we all know about it. We'll discuss about it very briefly in the next few slides. But that's, again, that's another reason. If you see only floaters, if the patient can see floaters, don't worry much. But if there are any flashes, that could be a sign of traction coming on the retina from the vitreous, and that needs to be assessed as soon as possible. Primary open-angle glaucoma, usually it's asymptomatic disease. However, it's exactly the opposite compared with the macular pathology. So the patient will be losing the peripheral vision, and then the central vision can be affected lost. So that's why it's a silent disease initially. Any patient with a previous family history of glaucoma, they need to be sent to their own optician for screening if they have any concern about their vision. The last, obviously, thing which can cause painless change of vision is losing part of the vision, like hemianopia, as I showed you initially. And that can be related to CVA or vascular pathology, like stroke, and that needs to be seen as soon as possible as well. So hence the confrontation visual field in such case can be extremely useful. And it's very common for people to say, I can't see in my right eye. And then when you do the confrontation, you see that they can't see on their right part of their vision in both eyes, not only the right eye. And again, that's rather than sending cold referral, those patients need to be sent directly. So again, confrontation visual field can be very useful. The painful sudden loss of vision, not the painless. Acute angle closure glaucoma, as we said, you need to ask about headache, you need to ask about pain, vomiting, feeling unwell, blurry vision, pupil will be fixed and dilated. So all these things, they come together, and those patients, they need to be seen as soon as possible. But usually they won't come to you. Those patients, they will come directly to eye casualty because they will be in severe pain and feeling unwell. Keratitis or corneal abscess, any patient with a trauma, any patient with contact lens, who are contact lens wearer, you need to think about this as a differential diagnosis, any painful sudden loss of vision. Severe uveitis, as we said, check the history, check the immune disease. Optic neuritis, usually it affects young people, and there will be pain on eye movement. So those people they will have kind of a headachy pain all the time. But whenever you ask them to move their eyes up, down, right, left, they will have severe pain on eye movement. So think about optic neuritis. And lastly, the GCA, which is always the main concern from your point of view, our point of view, I think any clinician point of view, because it can be disastrous. It can cause not only loss of vision in one eye, in 25% of cases, it can cause loss of vision to the other eye, and it needs super urgent treatment with the steroids, and it can cause stroke, it can cause heart infarction. So that's why this needs not to be missed. So here, always ask about headache, temporal tenderness, and do confrontation visual field, please, because that can be very useful in picking up the peripheral loss of vision, which can sometimes start with, and a lot of elderly people, they will not notice this unless it becomes significant. Flashes or floaters. Red flags refer directly without even asking if you have sudden onset of flashes and floaters together. Because whenever these are two together combined, it means that the vitreous has detached from the retina and it is causing traction. So that's why they need to be seen in the eye casualty. Or if there is any permanent loss of vision or visual field. So if the patient lost their vision, obviously that's most likely a retinal detachment, especially if this is proceeded or came before that with the flashes and floaters, and then they lost the vision. Or if they lost part of their vision, so that could be localized retinal detachment, which is not involving the macula yet. Ask about the previous history of family history of retinal detachment, high myopia, because it's mostly affect high myopic patient, or trauma. So all these things in any flashes and floaters, they need to be referred as soon as possible. If the patient is only mentioning about floaters, no flashes, they can be seen by their own optician on cold basis. I wouldn't really panic and send them directly to eye clinic or eye casualty. Light sensitivity, again, red flags, any reduced vision with light sensitivity, because it can be uveitis or infection, as we said, contact lens wearer. So this needs to be sent as soon as possible. You can treat, depending on the severity of case, if this is chronic and bilateral, because it can be dry eye or blepharitis, or sometimes cataract itself can cause light sensitivity as a form of glare more than anything else. So you need to distinguish, is it painful when you have exposure to the light, or is it like you feel uncomfortable to look while driving, for example, or because if that's glare, that's not light sensitivity. And sometimes it can be tricky to distinguish from the patient point of view. So you have to be very specific. So I finished the first part, which is mainly about the history. And now we'll combine this with a lot of clinical examples for discussion. And we'll try to apply the previous slides into practice. So before we move, any question, please?
Oh, yes, there are questions.
Yeah, sure.
First question, do we refer possible GCA to you guys or rheumatology?
Yeah, thank you very much. That's extremely useful to know. So any loss of vision to us. If there's no loss of vision, and if you are the patient is having pain, temporal tenderness, but the vision is absolutely fine, please don't refer to us, because all we are going to do, we are going to send to rheumatology. And that's why the confrontation visual field can be extremely useful, and checking the vision in your GP surgery can be very useful as well.
Next question, how high is the myopia to cause retinal detachment?
Usually the axial myopia is, we're talking about -6 or more. However, I would say any myopia, -3 or more, it needs to be kind of taken with like kind of suspicion. But usually -6 or more, we consider this as a high myopia.
I can see there are hands up, but I'll just do the questions in the chat and then I will come to you with your hands up.
Sure.
What about flashes with no floaters?
Yes.
Urgent, question mark.
Perfect. So flashes, no floaters. Still, if this is proper flashes by definition, when the patient is mentioning something like bright light, only for a second and then disappear. And most of the time it happens during the dark, like even in dim room or anything like this. So that needs to be distinguished from the zigzaggy lights, which can happen during the migraine or these kind of things, which can last for minutes. And usually it comes in the periphery and start from the periphery and then kind of try to spread towards the center. So if this is proper flash, only for a few seconds, comes and goes, it has to be assessed as well, because not all the people, they will have floaters if they have retinal detachment.
Thank you.
Okay.
Next question. What do you recommend we do with the patient with recurrent uveitis who refuses to come to eye casualty? If we've documented recurrences and ophthalmology letters, should we treat?
Yeah, again, that's a very common issue. Now, the trouble is, if you treat and if you suspect uveitis, which is fair enough, I completely agree. You can give the initial dose of treatment, but I wouldn't really leave it completely without having ophthalmology assessment, especially contact lens wearer, because it can easily be mixed with keratitis. And even for us, sometimes they come to us and you see a lot of cells in the anterior chamber, and even us can be it can be suspicious. Sometimes it can be infection or uveitis. So if you see any signs of infection, don't, please. However, if the patient would like to postpone coming to eye casualty for 24 hours or so, I can see a big problem by giving the dose for 24 hours, but they need to be assessed definitely, because we can't suppose this is uveitis. Every single red eye is uveitis.
One more question in chat and then we will come to the hands up.
Sure.
What about shingles near the eye but not involving the eye? Do we need to refer as urgent to you or treat the eye?
May I ask to postpone this just for a few minutes, because I'm going to talk about this in details in one of the slides.
Okay, thank you. Panna, you have your hand up. Would you like to ask your question?
I was going to ask you if you could elaborate what the visual field defect is in the suspected temporal arteritis, please.
Yes, sure. The temporal arteritis, usually you get optic neuropathy. With the optic neuropathy, the most common thing could be enlargement of the blind spot, or the lower part of the field will go completely, which we call it altitudinal visual field defect. So it can come in a different pattern, but I think the most common thing is you need to focus on the lower part of the visual field, which is not respecting the midline. It can be respecting the horizontal line rather than the midline, and try to check whether the blind spot is enlarged. However, that's the most common pattern. It can come in any pattern really, but that's the most common pattern.
Thank you very much.
Thank you.
Those are all the questions. You may continue.
Okay, thank you. So now I think it's a shame that we have this meeting virtually, because ideally this needs to be very interactive. But anyway, let's just try to make it straightforward and simple. So we'll show a lot of examples. I'm not going to summarize the whole ophthalmology here, but possibly, in my opinion, these are the most common things which you may see in your GP surgery on a daily basis. So start with the eyelid. Lesion, like if the patient comes to you with the acute kind of swelling of the upper lid, the lower lid, whether you see bumpy area or not, regardless. So that's the most common thing, is a stye. Stye is when you have acute infection of the gland, which produce the tears here between the eyelashes. And that's most of the time is Staph aureus infection. It's like small abscess. So these cases, it usually comes with the blepharitis. So again, if you have a direct ophthalmoscope and you put on a high magnification with high plus, you may see the blepharitis here, which is the injection of the margins of the eyelid. So if you have stye, you need to treat with the topical antibiotic, as we all know. The most important thing is to use cold compresses, not hot compresses. Hot compresses is not good in the stye because it's acute abscess. You are making the inflammation worse. And if you have any doubt that this stye is kind of expanding and can cause cellulitis, please start the patient on oral antibiotic as well, especially kids. In my opinion, again, my humble opinion, any child under the age of 10 I have very low threshold to start them on oral antibiotic if they have STI, because it can easily spread and cause periorbital cellulitis and even orbital cellulitis. It's not catchy, so don't worry about it. Don't ask them to, obviously they need to clean their hands and everything, but it's not contagious. Lastly, if you have any doubt that there is periorbital cellulitis, ask the mom to take photo and compare. If this is expanding, even during the overnight or during 12 hours, they need to come to eye casualty as soon as possible, because with kids, you never know. These things can very easily turn into orbital cellulitis, only from this area to periorbital to orbital. The other differential diagnosis is chalazion. With chalazion, this acute stage is gone. Now we have the chronic stage, which is the granuloma, lipogranuloma actually. And at this stage, unfortunately, nothing is going to work. All you can do to advise the patient, if this is tiny one, not as big as this one, to use hot compresses, obviously not very hot, I would say warm compresses, because it can help in draining the contents of it. It's not even inflamed. And you can ask them to do massaging, and you can always give chloramphenicol ointment just for possibly 2 weeks and see how it goes. But in my opinion, this will never go. So you need to refer to the eye clinic. In the eye clinic, we need to drain this, not on acute basis. Or if this is tiny one, we inject steroids in the lesion, which should take care of it. But most of the time, it needs to be drained from inside the lid itself. The most common treatment for any recurrent STI or chalazion is doxycycline. So if you have a patient who's having this on very recurrent basis, especially if this is combined with the blepharitis, you need to give course of doxycycline. I usually give it for 3 months, depending on the weight and the age of the patient. I don't give it to kids because of the contraindication, as you may know, regarding the bone and the teeth. And that's very, obviously, it can be very helpful in stopping this from recurring. Differential diagnosis of the STI or the chalazion, you have cyst of Zeiss. Cyst of Zeiss is filled with lipid, and usually it comes on the margin because it's one of the glands is enlarged, but it will never come inflamed, and it won't be very deep like the chalazion itself. It will be superficial. Cyst of mole, it's filled with water or liquid, sorry. And again, that's one of the glands on the margin of the eyelid filled with the fluid. You have epidermal cyst, which will come away from the margins of the eyelid, and you have the dermoid, again, the same thing. So that's the differential diagnosis of the chalazion. Things which need to raise suspicion from your point of view, and you need to treat in a different way, not as chalazion, like I'm talking about malignant issue. If you see any loss of eyelashes in the area of the chalazion, that's very suspicious, because usually chalazion will never cause loss of eyelashes. If you see ulceration, like for example, again here, there is a loss of eyelash. If you see ulceration, especially if this ulceration is expanding and filled with keratin, this is bad. Or if you see distortion of the whole anatomy, which is obviously very significant, again, that's bad. But I think the most, or the early sign is always loss of eyelashes. And the other thing which I meant to tell, if you see any recurrent chalazion, which keeps happening, so that's need to be raised kind of clinical suspicion that it could be malignant. So again, if you have very recurrent chalazion not responding to the treatment, including the doxycycline, it has to be referred, please. Blepharitis is when you check the margins of the eyelid here, as we can tell, and it can be inflamed. From your point of view, it's very tricky to distinguish the types of the blepharitis, but all you need to do is, hopefully, if you have the machine or the equipment, just to check the margins of the eyelid and see if they are quite injected. So that's most of the time blepharitis. And blepharitis will always come with dry eye, because the mechanism of the blepharitis, it will plug the glands which are producing the tears or the lipid layer of the tears, and that can cause a quick evaporation of the actual watery layer of the tear. So that's why they always come together. And when we treat the blepharitis, we treat blepharitis and dry eye. And the most acceptable regime of treating this, I think from your point of view, is always these advices. So you need to advise the patient to use warm compresses. I wouldn't say cold, warm compresses, and they can buy it over the counter. There are many types now to buy for lid hygiene. Artificial tears is always very helpful, and please consider preservative-free artificial tears, because if you consider the preserved version, you are increasing the inflammation in the eye, and that's not going to be helpful. So artificial tears has to be the preservative-free. Sunglasses, clean eye, and use humidifier. Stay hydrated. All these are obviously for mild dry eye or blepharitis. From our point of view, is different story, because we see the more advanced cases. And here in these cases, I would still consider steroids. I would consider doxycycline, vitamin supplements, a lot of other things. But I think from your point of view, that's all you need to do. And if this is still causing trouble to the patient, please send to us, and we'll be more than happy to deal with. But I think these two are the most important things, the lid hygiene and the artificial tears. There is only one special type of blepharitis. If you see severe blepharitis or like recurrent dry eye, recurrent stye, recurrent blepharitis, and that's the shape of the face, they have quite a lot of acne and rosacea. This is really, I wouldn't bother even about treating it, just refer to us. The reason why, because it can be very aggressive type, they need steroids, and the keratitis or the inflammation of the cornea, in addition to the corneal ulcer, are very common. So always check the shape of the face, and if you see this, these signs, please refer to us, even if this is kind of slightly red eye or slightly discomfort, causing discomfort, because that needs to be possibly given steroids and doxycycline for a long time to heal. Moving to the bacterial conjunctivitis. Bacterial conjunctivitis, usually it's a self-limiting disease. It's not really anything to worry about most of the time. However, you need to distinguish this from other type of conjunctivitis. Usually, if it's really bad, you will see swollen eyelids, slightly swollen eyelids. The most common sign is the discharges. There will be a lot of pus coming from the eye. The patient will wake up in the morning and the eyes are almost completely closed, or at least this corner here, the nasal corner, will be kind of stuck together, the upper and lower lid. And this is the type of the pus you see, the discharges, which you may see in the bacterial conjunctivitis. The whole eye will be quite inflamed. And ideally, the bacterial conjunctivitis will never cause swelling or tenderness of the lymph nodes, unless if this is gonococcus or chlamydia. Chlamydia and gonococcus will definitely cause non-tender, non-painful swelling of the lymph nodes. If you see any of these, especially in very severe cases, again, you need to refer urgently. Treatment-wise, sorry, I didn't talk about this. Treatment-wise, you need to give antibiotic, more than enough chlorphenicol, or possibly anything similar, unless if the patient is contact lens wearer. So contact lens wearer, they need to be sent directly to us. The most important thing, which we always forget about, is ask to kind of have their own towel. They have good hygiene, not to touch anyone, especially if they live with kids, because that can be very catchy, the bacterial and the viral conjunctivitis. The viral conjunctivitis is very similar to the bacterial from your point of view, but only, in my humble opinion, two differences. So these we see under the microscope. I just wanted to show you this to see how we distinguish between them. But in the viral conjunctivitis, which is here, obviously, that's the bacterial. We see papillae under the upper lid, and the viral, we see the follicles. In the viral conjunctivitis, usually it comes after viral disease, not all the time. It may happen without. Extremely catchy. Adenoviral conjunctivitis is very catchy. The discharges usually are not as bad because the patient will have very watery eye rather than mucus or pus coming out of the eye. unless if they have very advanced and severe adenoviral infection, which can cause pseudomembranous type, and that can cause mucus. But usually it's watery discharges, it's not even pus or anything like this. And the other thing which can be, again, very useful to check for the lymph nodes. With the adenoviral infection, the lymph nodes will be enlarged and tender. As we said, with the chlamydia and even gonococcus, they will be enlarged but non-tender. The adenoviral is marked really sign. It's just to check the lymph node, they need to be enlarged and tender. Not in every case. Again, I'm just trying to say this is the typical picture. So if you see these, be just directed, it can be adenoviral. I'm not expecting you to do a swab. However, if you have access to swab, that can be extremely useful. So you can do the swab after everting the upper lid or even from the lower fornix. Do proper swab. So you have to make it really kind of proper swab, not only touching it. And so that's why you have to numb the eye before doing this. So that can give you even more clue. The treatment, again, I would still consider the chloramphenicol as an option. It's not going to be very helpful, but this is just in case if there is secondary infection. Hygienic advice, extremely important, because that's even more contagious compared with the bacterial one. And they can have some painkiller if they have pain, especially if they have headachy pain or these kind of things. Sometimes if they have a lot of discomfort in any type of conjunctivitis, you need to prescribe artificial tears. But usually that's not indicated. In very advanced cases of viral conjunctivitis, when the cornea can become affected, we give steroids, but not all the time. The allergic to conjunctivitis, again, I just wanted to show you this slide to see the difference between the type of the eyelid reaction. So for example, this case, she had allergic reaction to something. And the reason why I'm saying this is allergic compared with the other one, the eyes are white, as you can tell. You need to ask in the history whether they changed their, for example, makeup, they changed their shampoo, or they had any exposure to something unusual recently, or if this is a recurrent issue. Because if this is a recurrent issue, especially if this is combined with other atopic disease like eczema, asthma, these kind of things, so think it could be most of the time allergy, and there is no harm of treating with the chloramphenicol, but you need to consider antihistamine in these cases. This is another type of allergy, but this is related to eye drops. So if you see any patient, especially glaucoma patient, who are coming to you with the crusty, dry skin around the eye, even the eye can be watery and red, before treating this as a bacterial conjunctivitis, the most common reason all the time is the glaucoma drops. And the most common reason of the glaucoma drops is something called Lumigan, which is, in my opinion, it's, I don't like Lumigan because obviously it's like torturing to the patient, but that's the most common reason of the having this allergic reaction around the eye or in the eye itself. And lastly, again, this is another sign of some kind of atopic dermatitis. So this patient you need to ask about eczema, asthma, kind of anything related to this, and then you can get the diagnosis. The allergic conjunctivitis usually is slightly different from the other two types. It comes with chemosis. So most of the time you will see a lot of kind of swelling in the conj. So the conj will be full of fluid. It can be very itchy, and it can happen in three forms. First form, if they are exposed to something unusual, as we said, they change something, or it happens after swimming in a swimming pool with a lot of kind of high concentration of chloride or these kind of things. The other type is the vernal type, which can happen on regular basis every single year during the spring or autumn, whichever. And that can be most of the time already diagnosed. And the third type is the atopic. Atopic for people who are known to have multiple allergic reactions to a lot of things, including obviously autoimmune disease or allergic reaction like eczema, asthma. So these things you need to ask about before concluding. And most of the time, allergic conjunctivitis is bilateral, not unilateral. And the most common symptom is itchiness and discomfort. And the most common sign is this chemosis in addition to mucus coming out of the eye itself. So mucus is the one which you see in early allergic conjunctivitis, not like the viral or the bacterial as we already discussed. So this is again to confirm viral watery discharges, bacterial purulent, allergic mucus coming out of the eye. There are other types which I'm not going to talk about. If you suspect chlamydia, especially if you have conjunctivitis in one eye only, not both eyes, in a kind of young patient, not elderly patient, and this conjunctivitis is not really recovering after 1 week, please have high suspicion that it could be chlamydia. And if that's the case, if you don't have facility to do the swab, just send to us, because the problem with the chlamydia, it can easily affect the cornea. And once it affects the cornea, it can be really tricky to treat and it will leave scarring. So that's why it has to be picked up at early stage. So always, if you have unilateral severe conjunctivitis, not really responding to treatment after a few days, just send to us and check for the lymph nodes. As we said, it should be enlarged and not tender, as for sexual history as well.
I have quite a lot of questions before you carry on.
Yeah.
Is it an appropriate place to stop?
Yeah. We'll pause now and then we'll carry on. That's
okay. Fine. Quick fire questions. Which oral antibiotics do you prefer for STI?
For STI, I usually start with the chloramphenicol, because at the end of the day, it's not going to make a difference. STI is like granuloma tissue, really. We only give it just in case if there is any component of blepharitis. So it's not going to make a difference. Chloramphenicol is more than enough, but sorry, I'm talking about the chalazion. The STI itself, chloramphenicol again is enough, but if you're talking about the oral antibiotic, I usually give co-amoxiclav because I know that you don't prefer to go for that option, but for kids, I would go for that option. For elderly, I think you can give possibly something less than this, but again, still in the hospital, we go always with co-amoxiclav.
Thank you. Which lymph nodes swell in gonococcus/chlamydia?
So we always check in front of the ears on both sides and below the jaw, again on both sides. So these are the lymph nodes to check. But again, I'm talking about the typical cases. So if you see all these together, it can be typical. Not every case you will see these enlarged. But usually the place to check is in front of the ears and below at the almost at the angle of the jaws, under the jaws.
Do we refer all neonates with conjunctivitis, and how urgent? Should it be same day?
Same day, I agree completely, because those are at really high risk of having gonococcus infection, chlamydia infection related to the delivery. So any baby, especially if within the first possibly 10 days to 14 days of delivery, if they have conjunctivitis, don't hesitate, just refer.
To you or to pediatrics?
Ideally, you will be sending to pediatric and they will call us.
Okay, next question. Does acute uveitis need to be referred urgently? Same day?
Again, it depends on the time. If they come in the morning, for example, and they have a lot of photophobia and red eye, yes, please. However, if you see towards the end of the day, it's not too bad. No, it's not urgent. You can send next day.
Okay, 2 more questions. How do you treat chemosis with allergic reaction from food and vision otherwise normal, child EpiPen carrier, no ABC compromise?
So if this is definitely like bilateral, not unilateral, so just give antihistamine and cold compresses, nothing else. No need for antibiotics, especially if there are no signs of infection, no red eyes and nothing like this. Usually the cold compresses can help a lot in reducing the itchiness and the irritation, and the antihistamine should help as well. Regarding the drops, if the eye is very itchy, I usually give them antihistamine drops as well. Like, there are many options in the I don't want to refer to anyone, but artificial tears could help as well, depending on the status, how bad it is. Steroids only if this is very bad inflammation with a lot of itchy eyes.
Last question, and then I'll let you carry on.
Sure.
Can bacterial conjunctivitis lead to periorbital cellulitis?
Yes, definitely it can, especially in kids. So that's why in kids you never know what to expect. When I say kids, I'm talking about less than 12 years old, ideally less than 10 even, but I would just go slightly more generous up to 12, because their orbital septum is not well developed yet. And because it's not developed, the bacteria can easily penetrate and go deeper and deeper. So that's why you have to have low threshold to give oral antibiotic and always refer if you need to.
Thank you. You asked me to let you know about timing. We've got 5 to 10 minutes.
Yes, sure. We'll try to my best. So benign red eyes, very clearly, subconjugal hemorrhage. If you see subconjugal hemorrhage, you need to check blood pressure. The first thing to do, check for constipation, coughing, anything which can cause increased pressure in the upper part of the body. But most of the time, it has nothing to do with anything. And just it needs reassurance, no need for treatment. Pterygium, when you have this tissue expanding towards the cornea, it can always get inflamed on and off, and that's in itself, it doesn't mean that we have to be concerned. However, if the patient is really having a lot of issue, you need to refer to consider surgical removal, but in itself, it doesn't really cause any issue, especially if this is stable, if this is not expanding. Herpes, I think I just asked to postpone the answer. So because we don't have enough time, I'm just going to make it kind of simple. So always when you see red eye, regardless if you see it like as a conjunctivitis or other differential diagnosis, check for the lesions on the skin around the eye. And sometimes these lesions can be very subtle, and really you may not even notice them unless if you look through the hair. So you need to always look through the hair, and sometimes you will be surprised that they can be at the early stage not even visible significantly here, but you may see them here. When to refer, if you see a patient like this lady, for example, she has white eyes, completely white eyes, the eye is not involved, she has shingle on the right side, but the tip of the nose is involved, that's, we call it Hutchinson sign. Once you see the tip of the nose involved, that's mean the risk of the eye to get involved, especially the cornea, is quite high. Please refer. If you don't see the tip of the nose involved and the eye is fine, no need for referral. Just give antibiotic and ask the patient to report if she has any problem. But if the tip is involved, send to us. The other thing, if you see young patient with really bad shingle, without any history of immunosuppression, think HIV, especially if this is recurrent. So any bad shingle in young patient, I would always consider doing HIV test. Corneal foreign body and corneal abrasion, I think this talks about itself. The abrasion, you need to put fluorescein to check, and all you need to give is antibiotic and artificial tears, preservative-free. It will heal by its own. Foreign body, you need to send to us to remove. Very important to try to evert the upper lid to see if there is any foreign body hidden here, because sometimes, or in many cases, you will see abrasion, and the patient said, I can't remember any story of trauma, but then if you evert the upper lid, you will see foreign body here rubbing against the eye. So it can be very useful if you learn how to do it, and you can check before sending the patient. Keratitis or corneal ulcer, any contact lens wearer, you need to put fluorescein and look for the sign of the keratitis or the corneal ulcer. It can be bacterial, it can be dendritic, as you can see in the viral or herpetic infection, especially if you see hypopyon. Hypopyon is the pus inside the eye in the anterior chamber, and that can be a sign of Pseudomonas, and that can be very nasty infection. So those cases need to be sent as soon as possible. Acute angular closure glaucoma, we already talked about it. Semi-dilated, fixed, non-reactive pupil, painful, photophobic eye, headache, vomiting, feeling unwell, cloudy cornea. So these things need to be sent as soon as possible. Chemical injury, only one thing to think about, if you distinguish, if this is kind of alkali chemical injury, always think washing the eye itself, it may not be enough. So if the patient had chemical injury related to these bleaches at home or something like this, that can carry on penetrating despite washing it and everything else, not like the acidic one. So that can be very serious and needs to be sent. And if the patient lives in a slightly remote area, I would definitely encourage all the GP to wash if they have the facility at their GP surgery before sending, because making the pH neutral can be extremely useful before sending the patient to us. Episcleritis and scleritis, it's just the deep layer of the conch can be extremely injected, and the distinguish between them, episcleritis is mild discomfort only, but with the scleritis is severe pain, and scleritis always come with autoimmune disease, not always, most of the time come with other autoimmune diseases. Uveitis, we already talked about it, which is the autoimmune disease inside the eye, which can be related to the eye itself, or it can be related to other autoimmune disease. Here, I just want to show you one thing. Not every red eye is just related to eye pathology. Like, for example, always check for orbital signs. In this case, you can see the retraction very significant with slightly red eye. So any retraction, you need to think about the thyroid eye disease. In this eye, you see very inflamed eye, but a lot of chemosis on one eye and around the eye itself on both sides. So that could be, whenever you see such case, it can be either thyroid eye disease, it can be fistula, which can cause this. And that again can be very serious, especially if this is sudden onset. So always consider referring these patients to us if there's a bit of proptosis, which is obviously significant here as well. Again, this is the eye itself, it's coming down compared with this eye, and that can be related to mass or tumor or even thyroid eye disease, other things. So if you see any of these things, refer to us. So always check for orbital signs, not only for the eye. Babies, we already talked about it. So if you see any cloudy cornea in baby, it can be systemic disease, metabolic disorder, or it can be congenital glaucoma, which can cause this. So it has to be referred as soon as possible, because the high pressure in babies will cause very blurry or very cloudy cornea. As we said, the babies will have always low threshold to develop orbital cellulitis. So always consider treating them with the oral antibiotic. And if you are suspecting in new babies any kind of significant conjunctivitis, refer to us, because chlamydia or gonococcus could be the reason in babies, especially the first couple of weeks of their birth, and that needs to be treated not only from the eyes point of view, from the systemic point of view, because it can cause a lot of systemic infection, including the lung infection and everything else. So it's not only about the eye itself. Cataract, I'm not going to talk about it. Only the last 3 slides, Mel, almost finished. Optic disc, we have two kind of picture in contrast. We have the papillary edema, when you have kind of the whole optic nerve, it can be very swollen. And the first thing you need to check the other eye. If you see this swelling in both eyes, so you need to make sure you are checking the blood pressure on the day, because the most common reason could be very high blood pressure, malignant blood pressure, retinopathy related to hypertension, or it can be tumor inside the eye or IIH. And all these needs to be obviously referred, but you can pick it up by doing the simple test which we talked about. And the exact opposite, as you can tell, if you see very cupped disc, so exactly the opposite. This one is bulged, this one is cupped, very cupped. So that's how the glaucoma looks. And you'll be surprised, especially during COVID, we are seeing patients in the clinic who just went for routine eye assessment to their optician, and by chance, surprise, surprise, they were found to have extremely advanced glaucoma, almost loss of vision, because the glaucoma patient will never notice their problem unless it becomes really very advanced. And that's why if you can do this check, it can be useful in sending those patients to optician, not to us, obviously, and then the optician can decide. Macula, you have 2 types you need to distinguish between, if you can. age-related macular degeneration, which is this one. The whole retina is fine, everything is fine, but you see bleed in the center and some signs of tear and wear. Or if you have vascular disease, including diabetes affecting the macula, those people will have mainly problem in the central vision. And the most useful tool for this is advising them to use Amsler grid. Amsler grid will distinguish between any macular pathology or any other pathology. If they are saying we have a lot of distortion in the Amsler grid, so that's most likely macular pathology. And that's another way of distinguishing the pathology on, is it on the optic nerve, is it in the macula? And Amsler grid you can easily download from the internet. We talked about the vitreous detachment and the retina detachment. Vitreous detachment, when you have the vitreous itself detached, but the retina is still intact, which is the yellow part here. Once the retina starts to become separated, that could be where the patient will notice visual field defect. If this is going to be treated on time without the macula being affected, they will still have 6/6 vision without any problem. However, once this fluid expanded and involved the macula, even if they have surgery, they will have permanent kind of loss of vision. So that's why it's very important to refer any patient who you suspect retinal detachment at early stage, because their vision can be saved on time. Last couple of slides. Anterior optic neuropathy, we have two types, non-arthritic or arthritic. Arthritic is the GCA, non-arthritic when you have other factors, including the blood pressure, diabetes, these things. There is no treatment for the non-arthritic because it's only about controlling the risk factor. For the arthritic, you have to admit the patient and start them on IV and oral steroids, not only for the sake of the eye, because most of the time, if the nerve is gone completely, like this is very pale nerve, the vision is not gonna be reversed, but to save the other eye, because the chances of having the other eye involved is 25%, which is very significant. Even with the steroids, without the steroids, it's even higher. And the chances of stroke or heart infarction is very high as well. So those patients will need to be seen on the day, being treated and admitted. Lastly, optic neuritis. Optic neuritis will never affect very elderly patients. It usually affects patients up to the age of 45. Pain all the time, like tenderness, but mainly while moving their eyes. There will be afferent pupillary defect, loss of color vision, and the whole symptoms will become even worse when they have hot shower or they have increased body temperature. And the most common reason, as we all know, is multiple sclerosis. So from your point of view, I think you can link things together and ask about other signs or symptoms of multiple sclerosis to know whether there is any link. The management, according to the optic neuritis study, there is no point of giving those patients oral steroids only. It's not going to make any difference. The only thing is they are recommending giving them IV steroids followed by oral. This is not going to make difference to the vision because usually the prognosis is good. Those people will restore their vision later. But they found that if you give IV followed by oral for a specific time, it will postpone the start of the multiple sclerosis. And that's the evidence about it. So that's why that's the most acceptable way of treating the optic neuritis in such cases. Sorry, that's the last slide, I promise. So the reason why I wanted to show you this, I know that you see a lot of patients with double vision and everything else. However, if you see, that's the red flag. If you see any dilated pupil and the eye is down and out with the ptosis, like the upper lid is kind of completely ptotic, you need to have high suspicion of third nerve palsy with pupil involvement. This is medical emergency because that's most of the time related to aneurysm in the posterior communicating artery, which can explode at any stage. So those patients need to be seen as soon as possible. However, if the pupil is not involved, if you have same size on both sides, so in these cases, possibly you can refer next day, because that's meaning it can be diabetes, it can be other things. But if the pupil is involved, definitely you need to refer as soon as possible. Thank you very much. Any questions, please?
I have a question in the chat for you.
Sure.
In patients with glaucoma who also suffer from overactive bladder, do you feel treatment for, e.g., solifenacin is okay if pressures are checked regularly?
So, sorry, what kind of agent are we talking about? If you can just tell me the name of the drug itself.
Is that the one that I said, solifenacin? I don't know if I pronounced it right.
I'm not 100% sure. I think I need to check it. Sorry, I have no idea. Possibly if you tell me the name of the drug itself, it can be easier for me to distinguish.
Charlotte, do you want to come off mute and ask your question?
I can check it for Sharon. What's the name? Sol.
SOLIFENACIN. She says, sorry, she can't get herself off mute. It won't work.
Okay. To be honest, I have no clue about, because I'm I'm dealing with a glaucoma patient on daily basis, but that's this particular agent. It never came up.
Visicare.
I have no clue, to be honest. I don't usually have any concern about this particular drug from the glaucoma point of view. The open angle glaucoma is absolutely fine because it's nothing to worry about. I'm not sure about the narrow angle glaucoma because that's the only thing which can sometimes be affected with anticholinergic agent. If this is anticholinergic agent, it can make the narrow drainage angle worse. And that's, it looks like by looking now, it is anticholinergic. So if that's the case, yes. If this is the narrow angle glaucoma, I would just recommend starting on the patient on this and at the same time asking us to have a look.
Thank you. Another question. Could you please tell about ptosis and DD and explain about the pupil again?
Yeah, so ptosis, you have many reasons for ptosis. The most common reason is involutional related to the age, and that usually comes by its own. However, when you see any ptosis, you need always to check two things. You need to check the pupil and you need to check the eye movement. If you see full eye movement, that's very reassuring. If you see any restriction of eye movement, so you need to think it can be kind of the third nerve, especially if the eye is down and out. To complete your assessment, you need to check for the pupil. If you see the pupil enlarged completely, that's very suspicious of third nerve palsy involving the posterior communicating artery. However, if you see the pupil smaller than the other one, so you need to think about Horner, which is the exact opposite from the pupil point of view. However, sometimes it can be tricky to know which pupil is the intact one. I don't think there is enough time to go through this. I'm more than happy because you need to check for dark and light, but I will leave it at this stage here. So check Horner, differential diagnosis Horner, or third nerve. Horner will cause meiosis, third nerve will cause dilation of the pupil, and that will come with the ptosis, both of them, obviously.
One more question. Eye drops for patients with glaucoma. There are periods where pharmacies cannot get stock and we are being asked to prescribe alternatives. It is a recurring problem. What would you advise we do?
Just let us know. I think we can prescribe the alternative, because from your point of view, you can only prescribe same thing, but with or without preservative. That's all you can do. But I don't think it's suitable for you to change the whole drug.
Okay, I think we've come to the end of our questions. So thank you so much for your time.
Thank you. And thanks for the GP colleagues for attending, actually.
Thank you all for attending. And I'm sorry my camera's not working. I will let you know when we have our next lecture organised. And I will also email out to you again with Mr. Otri's contact details and a link to the feedback survey. So thank you all very much for attending and hope to see you soon.
Thank you. Have a nice evening, all of you. Thank you.
Good night.
Bye.